This is a PowerPoint presentation on brachial plexus injury. The prevalence of brachial plexus palsy ranges from 0.2 to 2.0 per 1,000 live births, and the persistent weakness is present in 0.4 to 5 per 10,000 live births. Brachial plexus mechanism of injury is traction. The traction during delivery. The brachial plexus in babies can move significantly when we elevate or pull the arm, as you can see in this autopsy photo. Predisposing factors of the injury include the shoulder dystocia, fetal macrosomia, maternal diabetes mellitus, maternal obesity, and the prolonged second stage delivery. Clinical presentation. Most common type appears to be C5 to 7 injury. C5 to 6 injury causing Erb's palsy appears to be the second most common. And C5 T1 injury, total plexus injury, follows the next. Rarely, bilateral injuries can occur. We have seen 2 patients over the last 21 years of practice. The Plexus palsy was described as a CAT1 injury. This isolated injury we have not seen in our patients, and many authors, experts, doubted the existence of these isolated CAT1. Brachial plexus injury has probably been present throughout the human history. This painting in the 15th centuries. 15th centuries show the baby with the left arm weakness, which is similar to what we see in our modern patient on the left and the right side of the slide. It is important to keep in mind that threading nerve injury can be associated with brachial plexus injury. And this chest X-ray showed the elevated diaphragm due to left threading nerve palsy. It's also important to remember keep in mind that they developed the orthopedic deformities involving the entire upper limb, or a shoulder, elbow, or a hand. So it is desirable to have pediatric orthopedic surgeon on our brachial plexus clinic team. Types of nerve injury include the neuropraxia, axonotomesis, neurotomesis versus nerve root. The axonotomesis is mainly axon disruption injury, and the neurotomesis is a rupture of the entire nerve root. And the avulsion nerve root is a separation of the nerve root from the spinal cord. And these, the injuries occur in various combination. The great majority of the babies make a good recovery. Authors reported 95%, a complete recovery 95%, or 92%. But the number may not be accurate or diverse. The numbers may be present, but it's important to remember, keep in mind that the vast majority of them do improve, do make a spontaneous recovery. Rate of spontaneous recovery is important. If the babies are going to make a complete recovery, biceps and deltoid must show contraction by 1 month, and normal muscle contraction by 2 months. If the improvements are delayed beyond the 3 months, then they incomplete spontaneous recovery. For example, shoulder function, good shoulder function is not obtained unless biceps and deltoid contracts by 3 months, and complete by 5 months. And the poor shoulder shoulder function results if biceps and deltoid recovery begins after 3 months. Rate of spontaneous recovery is important. Basically, how fast they improve. If the complete recovery is to occur, biceps and deltoid begins to contract by 1 month, and normal muscle contraction by 2 months. A good shoulder is not obtained unless the biceps and deltoid begins to contract before 3 months, and complete recovery by 5 months. 5 months after 6 months, the recovery is not going to be significant. And poor shoulder resulted if biceps or deltoid recovery begins after 3 months. After 3 months, if they had greater than anti-gravity function in all biceps, triceps, and deltoid, after 3 months, they all made a complete recovery. If they had less than anti-gravity function in biceps and triceps and deltoid at the age of 6 months, they have the minimal. They made the various level of improvements from minimal weakness to severe weakness. So at the age of 6 months, the 6 months of age is the good time to determine the indication, determine the need for brachial plexus surgery. The management of the brachial plexus patients at the initial evaluation, we have to establish the diagnosis. Some babies were referred to us with the diagnosis of brachial plexus injury, and they turned out to have middle cerebral stroke or brachial plexus or soft tissue cancer involving the brachial plexus region. We do the neurological examination, and then some patients with the suspected the diaphragm paralysis, we obtained the chest X-ray. The main task during the first 12 months, is to determine the need for surgery. If we need to decide whether baby cell will benefit from the brachial plexus exploration and repair. Of course, we continue physical therapy. Indications of brachial plexus repair. The one is a flaccid entire upper extremity at the 2 months. Number 2, less than anti-gravity muscle strength with the Horner syndrome or pseudomeningeal at the 3 to 4 months. Number 3, less than anti-gravity strength of any muscle at the 6 months. Risk of a surgery includes a fretting nerve injury, pneumothorax, and subclavian artery injury. The fretting nerve can be damaged during dissection because it's right next to C5 nerve root. So the first step in one of the first initial steps of brachial plexus exploration is to locate the localization or identification of the fretting nerve. The pneumothorax can occur during the surgery on lower trunk because the chest cavity is right up below that lower trunk. Arterial injury or pneumothorax pneumothorax, we have not encountered this complication. Preoperative evaluation includes a neurological examination, PT evaluation, chest X-ray, and the C-spine MRI to rule out the pseudomeningocele. And EMG is not essential. Or we do not use the EMG for selection of the patients or follow-up of the patients. EMG is not helpful. We videotape all patients. Before surgery. This MRI shows the pseudomeningocele, the C7 and C7 nerve root and the C8 nerve root. This is all we can see on the MRI. We do not attempt to ascertain or interpret the status of the brachial plexus. We cannot clearly see the pathological findings. Brachial plexus repair procedures. The first priority is to improve hand and the elbow flexion, both of them. If the donor is limited, the nerve is limited, we do the graft procedures to improve the hand and the elbow flexion to reduce this disability. The surgery itself, intraplexural repair, we remove the remove the neuroma, resect the neuroma, and place the external nerve allograft these days. In the past, we used sural nerve graft. We also transfer C4 to supraclavicular nerve or part of the brachial plexus, for example, anterior division of the brachial plexus or posterior division. We also can do extraplexural repair. The ulnar nerve and the musculocutaneous nerve transfer, Oberlin procedure can be performed. We also transfer the radial nerve to axillary nerve to improve the deltoid. We also do the external neurolysis on children who show the initial improvements, but after the age of 6 months, they plateau. Say 6, 7, 8, or 8 or 9 months, they plateau, and we remove the scar tissue along this epineurium, and they can improve, make another recovery after the spontaneous, their own recovery. The brachial plexus, the incision for the brachial plexus, we use typically the longitudinal incision from the below the mastoid process to the clavicle. If infraclavicular exposure is needed, we can extend the incision along the clavicle down to deltoid groove, but almost always we use this longitudinal incision. At the time of surgery, we can observe neuroma, ruptured parts of brachial plexus, ruptured, the transection of the brachial plexus, or avulsed nerve roots, evidence of avulsed nerve roots. We do not see these avulsed nerve roots themselves, but nerve roots look atrophic, and sometimes we see the CSF leak, suggesting that the avulsed nerve root, which could be visualized on the preoperative MRI. The neuroma can have various shapes and severity. And this slide shows the neuromas, the upper trunk mostly, and the neuroma must be, we resected this neuroma and placed the external allograft or short nerve graft in many years ago. This slide shows the nerve grafting procedure, and on the left, we use a short nerve graft placed between the upper trunk and the C5-6 nerve root, and in another slide we show more extensive transfer procedures were combined, in addition to placement of the nerve grafts. We use the TCL to stabilize the nerve root nerve grafts, and we don't use nylon suture to fix the individual nerve grafts. Thank you for attention to this brief slide presentation.